The stories shared on It Takes Balls are unique to the individual sharing. Always speak with your trusted medical provider for treatment options specific to you. Welcome back to It Takes Balls, presented by Testicular Cancer Awareness Foundation. Today I'm excited to share a topic that I'm surprised I didn't think about before. And with a doctor from a country we haven't had one from before, Dr. Rob Hamilton from Princess Margaret Cancer Center and University of Toronto is a urologic oncologist, and he's joining us from Canada. Dr. Hamilton, thank you so much for being here.
Thanks, Stephen. I appreciate the invite. I didn't realize I was the first Canadian. That's very exciting.
Yeah. We're going to be talking about surveillance today, which is a huge topic because testicular cancer is predominantly a disease of survivors.
Yeah, it's very true. And I think perhaps different than your average cancers that in testis cancer, we have to think about not just the treatment and the cure, but what happens afterwards. And I think it may be different for other more advanced or aggressive cancers that occur in older people, but for young men that are predominantly afflicted with testis cancer, we have to, as clinicians, think about the next 30 and 40 and 50 years and what that might look like.
Yeah. So let's talk about what is surveillance? I know you sent me an outline of things that we could talk about, and you noted active surveillance or just surveillance. Is there a difference between those two?
Yeah, that's a good question. I mean, most of the time, no, those terms are used interchangeably. And that term sort of active surveillance only started becoming used, I would say, in the 90s, late 90s, 2000s. It started becoming more prevalently used. And I have to say, shout out to my colleagues here in Toronto. I think we were sort of the pioneers of that term of active surveillance, and certainly in prostate cancer with Lori Klotz pioneering the term. And then we've used it in kidney cancer and now in testis cancer for decades. And the idea, I think the term active was put on there because surveillance sort of implies you're doing nothing at all. And I think we wanted to get away from that concept because you are actually doing something. You're monitoring it very closely. Both the patient and the clinician team that are looking after you are monitoring it very closely. So it's not like you're just doing nothing towards your cancer. You're keeping a very close eye on it.
And kind of an overview of surveillance. I mean, when I was first diagnosed, I think I heard that it was going to be for 5 years, but then I hit my 5-year appointment and my doctor was like, all right, I'll see you next year. So, I mean, what is the period? How has it evolved over time? How can you speak on that?
Yeah, for sure. So, I guess first let's just set the definition of surveillance. So as I said, it's not the concept of doing nothing, but it's watching very closely. And usually, and we're speaking about testis cancer today, it's a combination of imaging and blood test, tumor markers, physical examination, with the goal being to try and identify a relapse early so that you can do something about it without trying to minimize the treatment burden and still keeping that excellent survival that we know is associated with testis cancer. So to answer your specific question, the type of surveillance, the intensity of the surveillance, and how long you are surveyed depends on where you are in your journey. So for example, if you're a stage 1 patient, and again, it depends, and we can get into the details as much as you'd like, but the length differs based on whether you're a non-seminoma or a seminoma. And we can get into the reasons why that's different if you want to. But in non-seminoma, for example, it is 5 years. And that's because if you've made it to 5 years and you haven't relapsed, the subsequent risk of relapse is so low that we feel that the burden of imaging you further, for example, with CAT scans and bringing you in to come to clinic and take a day off work and all that stuff is greater, much greater than the actual risk of relapse. Whereas in seminoma, we tend to watch people for 9 years, for example. And that just has to do with the dynamics of when the relapses tend to happen. And in seminoma, it takes a little bit longer to get to that comfort zone where we feel like the risk of relapse is low enough that we can discharge you from the cancer follow-up. And so it's different for different states of your testis cancer. If you've had chemotherapy, it's different. If you've had an RPL&D surgery, it's different. But the whole idea is we want to watch you until that risk of relapse is low enough that we feel comfortable saying goodbye.
Are you able off the top of your head to give some of those relapse chances for the different stages and
Sure.
cell types?
Yeah, sure. So let's just talk stage 1. It gets the Venn diagram gets, or the diagram gets much trickier as we get further. But if you talk about stage one for seminoma, average risk of relapse is 15%. And then we have some factors that help us, sort of bin you either one way or the other way on that average of 15%. For non-seminoma, the risk of relapse is 30% on average. And for non-seminoma, we have, again, some factors that can help us bin on either side and what we call personalize the risk for the men. So we say, okay, average is 30, but you're actually 15% risk of relapse. And whatever your risk is on that day that you're sitting in the office with your surgeon and you're reviewing your results and they say, oh, you're stage one, here's your risk of relapse. Whatever that risk of relapse is at baseline, every time you come back with a negative scan or a negative set of markers and everything is good, that baseline risk gets less and less and less. And the dynamics of that are slightly different. It goes down faster if you're non-seminoma. It starts higher, but goes down faster. If you're seminoma, it starts lower, but it takes a little longer for that risk to drop down. So I don't know if that we can go so much further into the weeds on that, but that's the general overview.
Yeah, I mean, as much into the weeds as you want to get, I think it'd be helpful for anybody who's just entering survivorship.
Yeah, sure. So let's talk about seminoma first. So I said 15% chance of relapse is the sort of all-comer statistic. And then the biggest factor that we have identified is tumor size. So the size of the mass, not the size of your testicle per se, but the size of the tumor in your testicle. And generally we put a cutoff of around 3 centimeters. So if it's less than 3 centimeters, then we say you're on the lower half of that 15%. So I tend to quote people 7.5%. And if you're greater than 15%, then if you're greater than 3 centimeters, then you're in that 15%, maybe even up to 18, as high as 20% bucket. If your tumor size. Now we've had some new data that's come out, and I think we haven't exactly known how to interpret it into the clinic, but people have gone back and looked at other factors on your pathology report, like invasion of the rete testis or the structures of the spermatic cord that come down into the testicle. People have looked at markers that have been elevated at the time of your surgery. We don't exactly know how. There's some scores that sort of your clinician may use to, again, give you a personalized risk estimate. But for seminoma, the vast majority are low risk. And so you're going to be 15% and probably even less risk of relapse. For non-seminoma, and then we can stop here and pause and check in and see how you are. The biggest thing for non-seminoma is this thing called lymphovascular invasion. And so when the pathologist looks under the microscope and sees whether the tumor is into the small microscopic lymph vessels or blood vessels, they'll describe this as lymphovascular invasion. And we know that factor drives you from, if it's not there, your risk of relapse is 15%. If it is there, your risk of relapse is 50%. So it's the lymphovascular invasion in the non-seminoma stage 1 space is a big deal. And there are others. So for example, the amount of embryonal carcinoma that you might have in your tumor seems to drive your risk of relapse higher. We're much less precise about that because the studies have looked at all different cutoffs. So I think the principle is the more embryonal you have, probably the higher your risk of relapse, but it never goes over 50% in non-seminoma.
So someone who's diagnosed with a kind of borderline thing, where they're on that 50% chance, it's going to be probably impossible for you to answer this. But I mean, how would you advise them to proceed? Should they be on surveillance, or should they kind of go proactive and do chemo and risk over treatment?
Mm-hmm. Well, it's a discussion. It's a really good question. A discussion that we have all the time in our multidisciplinary testis clinic at Princess Margaret. I think every patient, seminoma, non-seminoma, high risk, low risk, they should always hear all the options. And so you want to lay out, and the options are different, whether you're in seminoma or non-seminoma, but you should always lay out the options. And I think the important thing is, and I always say this when I'm giving talks, is that the discussion should not stop at that risk of relapse. So for example, suppose We say, okay, you're non-seminoma, all comers are 30%, but your risk is probably more in that 40 to 50% range as an individual. If you just stop and say, yeah, your risk of relapse is 50%, and yes, we could give you chemotherapy now, or we could take you to surgery now, and we would reduce that risk of relapse down in the range of 5%, let's say. If you stop there, that's a very dramatic, to go from 50 to 5, every patient would say, oh, well, of course, give me the chemotherapy, give me the surgery. But you have to go beyond that. You have to talk about, well, what is involved in chemotherapy? What are the short-term risks of chemotherapy? What are the long-term risks of chemotherapy? And that harkens back to how you kicked off the podcast talking about 30 and 40 years later, what your general health is as a survivor of someone who's had chemotherapy. So you have to talk about the side effects of the treatment. And then you also have to talk about what we call cancer-specific survival. So the risk of dying of testicular cancer is no different whether you choose surveillance or whether you choose to have chemotherapy right now. And the reason being, fortunately, for stage 1, if we watch you on surveillance and you're unlucky enough to relapse, we can rescue the situation with almost perfect recovery. So the cancer-specific survival for surveillance is 99% plus, which is exactly the same as if we gave you chemotherapy today, not knowing if your cancer was even there now. It's still 99% plus. And so those are you have to go beyond just that relapse statistic in the discussion with patients and with your doctor. If you're a patient, you have to ask them about this because you need to know about the side effects and then what the overall survival is going to be for you.
Yeah. And then I assume as the stages go on, I mean, somebody who's stage 3C is going to have, probably less option. I mean, they'll have the choice always, but they're going to probably be persuaded for that additional treatment.
Oh, yeah. So that's a very different discussion. So what we've talked about so far is active surveillance or surveillance as it applies to the stage 1 setting. The concept of surveillance can be there's different parts along the testis cancer journey that it can be applied, and we haven't gotten into that yet. But for example, if you have a small testicular mass, there may be a role for watching before you jump in there and do surgery. If you have if you've gone for an RPLND surgery and they found cancer, many places around the world will give you chemotherapy right away, but there's definitely an argument for surveillance after that primary RPLND. If you've gone for chemotherapy and you've had a nice response to your chemotherapy, there's a role for surveillance after that. You don't automatically have to go for an RPLND. And of course, we can talk about what the criteria are for that. If you've had chemo and surgery and they still find some tumor, a lot of places argue giving you more chemotherapy, but there's a role for surveillance after that. So there's a couple of places in your testis cancer journey where there is a role for surveillance. That example you gave where you're 3C, right off the bat, there's no question, like you have to have chemotherapy, like your physician team will recommend chemotherapy, and there's no role for surveillance in that distinctly advanced stage of disease. So the surveillance doesn't apply to all settings in cancer, in the testis cancer journey, but there's definitely some times where there may be a role for surveillance, and you have to talk to your physician about that.
Yeah. So for me, I was stage 2B. I'd finished chemo October 4th, and I ended up having RPLND on November 7th of 2019. My remaining mass was like a little bit over 1 centimeter. I guess that maybe I could have been surveilled. It ended up being scar tissue. But yeah, I mean, I don't regret having the RPLND, but maybe that would have been an opportunity to see how things developed.
Yeah. So Stephen, you bring up a very common scenario where the chemo did a nice job. It shrunk it down and it's at that just over a centimeter mark. And that's, we struggle with that in clinic. And we always get our medical oncologist, radiation oncologist, and me as a surgeon in the room. And we look at it together and we talk to the patient. And there may be a role for watching it a little further to see, like if you went from example, an 8 centimeter mass and now it's 1.4. We often say, well, let's watch it a little bit more and see if it shrinks below that 1 centimeter mark. And if it does, then definitely we feel comfortable watching it. If it stays at 1.4, 1.3, 1.2, you probably need that RPLND because and in your case, yes, they found scar tissue, and we know that 50% of those cases are going to be scar tissue, and so it's tempting for the patient and the surgeon to say, "Oh, I wish we had known." But the problem is we don't have a good way of knowing, and we're working on it. And the whole field of microRNA and liquid biomarkers, we're trying to solve that. But at this point, we don't have a great way of telling who's got just the scar tissue from who's got teratoma and who's got viable germ cell tumor left over after chemo. So we end up doing RPLNDs just like yourself, where you end up getting scar tissue. But I think you're right, and your take on your own situation is right. Is that we think you're better off having had it done for the masses that are over a centimeter than just sort of watching it, because you can get late relapse if you don't.
Yeah. How does the RPLND play into surveillance? I know primary RPLND is starting to become more common.
Yeah, so it's interesting. I think primary RPLND. So let's just put some parameters on it. So primary RPLND for stage 1. So again, this is a man who's had an orchiectomy, testicle removed, and no signs of cancer. A primary RPLND, I think, is being used less commonly than it was in the 80s and in the 90s and early 2000s. And I think because of the general acceptance of this concept of surveillance. In the setting of stage 2, like yourself, I think that we are using RPLND a little bit more often because we're understanding now that the long-term effects of chemotherapy, and there's been some really nice data coming out over the last 10, 15 years that shows that the long-term effects of chemotherapy are real. And of course, chemotherapy saves thousands of lives for testicular cancer. We need chemotherapy for testis cancer, but if there is a viable and safe way not to have chemotherapy, then we have to think about it. And so I think because of that, primary RPLND is being used more often. I didn't quite know your question. You said, well, how does surveillance apply to the primary RPLND setting? I think, if you and your physician feel you need an RPLND, there's for your stage 2 disease, there's not, a role for surveillance there. After your RPLND, there is. So if you do your RPLND, you find cancer. Depends on how much cancer, but you can have a discussion with your physician about surveillance after your primary RPLND. You don't automatically have to go for chemotherapy if you find cancer at the time of your primary RPLND.
Gotcha. Okay. I have a kind of a geopolitical question that I can edit out if it's totally off base, but with Canada kind of being the pioneers of active surveillance, do you think that comes from a place of the socialized healthcare and being more conservative on spending?
That's a great question. I don't think so. I really don't. I think it comes from a place of, us wanting to do what's best for the patients. And I really don't think that it comes from, it's not like, oh, I'd love to do an RPLND on you, but I can't because we don't have the OR time, or I'd love to give you chemo, but I can't because we don't have the chemo chair time. So no, I truly think it's about trying to maximize survivorship. And if we can avoid chemotherapy and still achieve cancer survival for you, then we've won. And I think that's where that's born out of, not so much resources. It's a good question.
I'm a complete idiot. I don't know anything about anything. So yeah, I mean,
that's not true. That's not true. I mean, I think there may be settings around the world where, people are, there may be a competitive market and people, may have a bias, probably unconsciously, but a bias, towards doing something for your cancer because there may be someone down the road or whatever who is, if they don't, then the person at the hospital down the road will. I can't speak to that, but so that doesn't exist in Canada, that sort of competition. But I truly think in Canada, it's born out of our understanding of the natural history and wanting to do what's best for the patients.
Yeah, I've got some questions here from Reddit in our Facebook group. So if you're listening and you're not in our Facebook group, I encourage you to join. It's Testicular Cancer Support Group. So this person asked 3 questions. We'll go one by one. How do we manage the concerns of fear of getting too much radiation from surveillance scans and needing to be on surveillance? Is there anything we can do to limit the exposure to the radiation?
Yeah, so that is a really great question, and it comes up in clinic increasingly often now, and that's because of awareness of this concept, and kudos to the internet, social media, everything for increasing awareness. And that what the question is getting at is that CAT scans, CT scans, come with a admittedly very small, but a small dose of radiation. And over time, over our lifespan, the amount of small radiation we get, including like when you fly on an overseas flight, you get a small dose of radiation. We all have like small doses of radiation in our basement from radon and things like that. So the cumulative exposure in life adds up. And we believe, and a lot of this is data that's been extrapolated from, for example, Hiroshima and other nuclear events, where we believe that the cumulative amount of radiation you get in your life can lead to the development of a second cancer. So not the testis cancer coming back, but like another cancer, a blood cancer, or another solid cancer. So the essence of the question there is, okay, you got diagnosed with testis cancer, and now you're going to get CAT scans at a regular interval. Are you harming yourself by getting these CAT scans? That's the essence of the question. And the answer is there's basically three ways to minimize the radiation from your testis cancer surveillance. One is to minimize the number of CAT scans you get. And I have to say, at Princess Margaret, we've worked hard to over the years, we've reduced the number of CAT scans that we use. And we've looked at our data, and it's our reduced number is totally safe, doesn't increase the risk of missing cancers and whatnot. So you want to talk to your physician to say, are we following the right schedule so that we're using the least number of scans and still catching the relapse safely? Two is minimizing the dose of radiation of any CAT scan you get. So we created this what we call low dose CT protocol at Princess Margaret, and we studied it, showed that it was just as good as the regular dose, and we published on that in 2008. So every single one of our surveillance scans is with this low dose, and it cuts the dose in half. And then the third is avoiding CAT scans altogether, and that's with MRI. You still need to have some imaging of your abdomen, and we now have data, and it's a little bit tricky to know how to interpret it and apply it to everybody. It's from seminoma, and so whether you can apply it directly to non-seminoma is tricky. But the MRI has no radiation. It still gives you contrast, gadolinium contrast. So there's pros and cons of both, but that's the third way is not getting CTs at all, but MRIs.
So you bring up MRIs and CTs. Sometimes people mention PET scans. So you touched on it a little bit there, but why would somebody get a PET scan versus an MRI or a CT?
Yeah. So there's also something that we see quite commonly. So I think we should be clear that there's really no role for PET scans in testis cancer in any setting other than seminoma that has had chemotherapy, and you're trying to see if there's residual disease left over after your chemotherapy. And even then, not every case should get it. There's some specific criteria. If your mass is greater than 3 centimeters, for example, and if you're enough, time out from chemotherapy, we don't have to get into the details of that. But really, that's the only time PET scan has a role. Otherwise, for testis cancer, you can find everything you need from CT, tumor markers, the occasional MRI for your brain, for example, if your clinician is worried about that. But PET scan really only serves that role. We see all too often PET scans are ordered for staging, or PET scans are ordered, on surveillance, and there's more radiation associated with that, and it sometimes can give you false positives, meaning there's stuff there that actually isn't there. And it could also give you false negatives, meaning it calls a mass negative, but in fact, that's a teratoma, and that needs to have surgery. So it can reassure you inappropriately both ways.
Interesting. All right. So we kind of touched on this guy's third question, but his second question was, are there any proven or studied tactics we can use to mitigate or combat the negative effects of scans before, during, or after?
Yeah, not really. I would say short of, so you get, if you're getting IV contrast, for example, the principle is to stay hydrated. If you're diabetic and you're taking metformin, you should talk to your doctor about stopping the metformin before you get the contrast. But there's really nothing you can do. There's no diet or hydration to mitigate the effects of the radiation. It'll be what it'll be no matter what your current state of your body is in. So the contrast is one thing, but for most young, healthy guys, whether you hydrate or not, very few of you will be on metformin anyway. So there's really not much you can do to mitigate the effects. Again, it comes back to that minimizing the number and the dose of radiation.
This one might be hard for you to answer because this is more for the patient, but why do people take surveillance so laxed? This person says, I've been stressed over and over again to never miss an appointment and to keep up with it. For me, it's a no-brainer to do that. I cannot fathom someone who would not.
Yeah, so that's a really good question. And when we talk about surveillance, and again, no matter where it is along the journey, if we're embarking on a period of surveillance with patients, we implore upon them that following up on time with their appointments, scans, and markers is imperative. In order for the principles of surveillance to work, where you catch the relapse early and can treat the relapse and still have the same cancer-specific survival, the patient has to buy in, and we have to try and stay on schedule. And I always say it's both of our responsibilities. So you have to attend the appointments for bloods and scans, and if you miss it, I got to make sure that I'm on your tail to go and do it. And so it's sort of a two-way commitment to adhering to the schedule. So I would hope that most patients on surveillance take that responsibility, just as this listener has mentioned. So I mean, you don't want to freak out about it, but you want to use your phone, set a reminder, put it on your fridge, whatever it takes to make sure that you stay on schedule.
Yeah, this one you touched a little bit on in the beginning. I mainly want to focus on the last part of it, but he says it's a long one. Can we get more of an explanation of how surveillance is designed to work? I've theoretically got a 10 to 20% chance of recurrence on surveillance, but I know overall about 30% of TC survivors have a recurrence. I think my odds are supposed to go down after 6, 12, 18, and 24 months, but I'm just not sure why or how this can be true given the other numbers, especially when I get on Reddit and recurrence rates seem higher, and that's probably just based on bias of who's sharing the information online.
Yeah, great question. We talk about this a lot in clinic too. And yeah, I think you're right. There is to do that last point first. I definitely think there's a bias. The people who are, perhaps afflicted more will be more likely to post online. And so maybe you get an online sense that bad things happen more often. So make sure you talk to your physician to get an accurate sense of what your specific relapse is. And yes, the concept is, and I touched on this earlier, but you get what's called a baseline risk. So the moment you have your testicle out and you meet with your doctor, that's your baseline risk. And we have factors that decide where that is for you. And then every time you come back and you have a negative or good negative scan or bloods, that risk goes down. It's what's called this conditional risk of relapse, and we published on this too. And if you want to look up that paper, you'll see we have a curve, and you can actually look where you are. You can say, oh, I'm 6 months out from my stage 1 seminoma based on these factors. I'm actually here, and you can get your specific time, or what we call conditional risk of relapse. And so what that reader or listener has said is exactly right, that it does go down. And I try to calculate that for the patients every time, because I find that helps relieve their anxiety for the next scan and the next visit.
Interesting. Okay. Yeah, I mean, we've had people on here who are 3-time survivors, which seems crazy because you only have 2 testicles. So, I mean, can you expand on, like, if somebody has it in their testicle, stage 1, and then a year later it comes back in the retroperitoneum, are they then a 2-time testicular cancer survivor? Or is it, I mean, how does that work?
Well, I guess it's a matter of semantics, and the patient can say whatever they whatever they like, to their friends and on their social media posts, and they're allowed to term it however they would like. I mean, technically, from a cancer biology standpoint, that is a relapse of the original cancer. So I wouldn't, it's still part of their cancer journey. And today we're talking about surveillance. When you embark on surveillance, that there's a chance that same cancer is going to come back. It was just hiding dormant. We couldn't tell it's there because it was so microscopic, and now it's grown to where we can tell it's there. So that's the same journey. So I think, as a surgeon, I would say that's, you haven't survived it once and survived it twice, but as a patient, you are allowed to do to call it whatever you'd like.
So if someone's stage 1 and they have it in their left testicle, are you surveilling like just the retroperitoneum for spread of that one, or are you checking the other testicle? Because technically the other testicle would be, a second cancer, right?
Yeah, so that there's a couple things in there that are very nicely tucked in there. So yes, so for stage 1, if we're surveying that, let's say a left-sided cancer for stage 1, yeah, we watch the retroperitoneum, depends on what type. Sometimes we watch the chest, we do blood tests, and that's to monitor spread of that left testicle elsewhere. There is a heightened chance for that man to have a separate testis cancer, a new testis cancer, not spread from the left, but a new event in the right testicle. And that risk is about 2 to 3%. It's a lifetime unwavering risk of 2 to 3% in that other testicle. So you say, well, do you monitor that, with ultrasounds or CAT scans? So we don't actually, because it's so low. There's very little utility in monitoring that other testicle. So how do we monitor it? We empower the patient to do self-exam and tell them, you do have a heightened risk in the other testicle, so you have to watch for it, feel it in the shower a couple times a month. And if you feel anything abnormal, you bring it to our attention, and then we'll get an ultrasound. And the vast, vast, vast majority, because the men are already attuned to what happened on the left side, almost always we catch the one on the right, if it's going to happen, at a very early stage. And so that's the way we monitor for this, what we call second contralateral primary testis cancers.
Interesting. Okay. Because I think around April, Testicular Cancer Awareness Month, I always start to feel an ache in my right testicle. And I've had 2 additional ultrasounds, but that would explain why ultrasounds aren't part of the, routine surveillance.
Yes. And so you actually raise a very good point. I mean, it is very common for men who have lost one testicle for cancer to have a heightened conscious, but also subconscious awareness of stuff in the other testicle, pains, aches, heaviness. And so we order a lot of ultrasound. We end up ordering a lot of ultrasounds on the other testicle for men because of that reason. And there's nothing wrong with it. That's just the brain protecting yourself from a second cancer event. And that's okay. So the fact that you've had 2 normal ultrasounds, that's totally fine. And that's what you have to do to make sure you catch it early on the other side.
Is there any risk to an ultrasound the way there is the minimal risk with a CT?
Great question. None. Ultrasound is the safest test, and one of the safest tests we have in medicine, thankfully.
I think we've covered this in other episodes, but just in case somebody's a new listener, I mean, what are the blood markers that you're checking in surveillance?
Mm-hmm. That's a good question. And it's not just in surveillance, it's also throughout your journey in testis cancer. We use these markers quite a lot. Thankfully, they're often informative, not always, but often very informative. So there's 3. There's the HCG, which is human chorionic gonadotropin, AFP, which is alpha fetoprotein, and then lactate dehydrogenase, which is LDH, shortened to LDH. So I won't dwell on it, but the third one, the LDH, is by far the least specific. So it's a general marker of inflammation. So if you have whatever inflammatory condition, a cold or a flu or COVID or whatever, it can go up. If you've had a recent surgery, it can go up. So just because you have an elevated LDH does not mean that you have testis cancer or that it's come back. So the HCG and the AFP are the 2 critical ones. And in fact, in stage 1, we've stopped checking the LDH because we've published a paper that shows that too often it's what we call false positive. And the patients understandably get all anxious. AFP, HCG is normal, but the LDH is elevated, and they come in saying, oh my gosh, my cancer's back. And we say, no, if the AFP and HCG are normal, we can completely ignore the LDH. So now we've actually stopped checking it in stage 1. It's still relevant in the rest of the journey, but in stage 1, we needn't check it anymore.
What about a couple of people that I know have had their RPLNDs at Indiana University have reported using a different marker from Natera. Is that something that's coming onto the scene more strongly, or are they kind of just testing something out?
Yeah, that's a great question. So yes, this is this burgeoning field of circulating tumor DNA. And I actually didn't realize that Indiana was doing this. And I'll have to talk to them. My understanding is it's very much still on the research front, and I would say in testis cancer we're behind the state of science in other urological cancers. That bladder cancer is probably the where we've had the most evidence, and certainly in Canada, there's definitely not standard of care for monitoring, even in bladder where we have the most evidence. So I think it's probably just at the research test level in Indiana. We'll have to check with them. We have other markers that we're starting to use more often in testicular cancer, like microRNA. We're exploring, and we're almost there where we're able to use that as a standard of care test, but not quite yet. So ctDNA, I would say, is a notch behind that. But that's interesting. We'll have to follow up with them on that, see when they're using it and how.
I definitely can't speak for them. These are just two people who have told me within the last 6 months they've had an RPLND, and I don't know. But let's use this as a segue into Canada-specific questions. And our board member, Tony Brown, whose son was treated for testicular cancer, in our group, she's very vocal about, U.S. versus Canada. So she's had lots of questions here. I sent you these beforehand. You probably saw. So we'll start with the first one. Because Canadians have socialized healthcare, we're not used to asking for a second opinion because either we don't know that we can, or it is extremely difficult to be referred to a second oncologist. Are Canadian patients told who their oncologist has conferred with?
Yeah. So thanks, Tony, for these questions and with the Canadian specific bent. I mean, I would say, yeah, my perception, I mean, I worked in the US in fellowship and in my master's before that. And so there's definitely a less utilization of second opinions and third opinions and whatnot in Canada. It may just have to do with geography. To get a second opinion, maybe a long way away geographically from you, whereas in the US where you may be closer to another expert provider. In Canada, I mean, we have resources for whoever's treating you, whether it's a surgeon or a radiation oncologist or medical oncologist. They have resources in Canada to get, quote unquote, expert opinions, second opinions. So for example, we have a testis cancer Google group. There's 100 members across Canada. It's all testis cancer experts across the disciplines. And I wouldn't say all the time, but very often we have cases that are posted and it's blinded, like there's no identifying information. And the details of the case are there. Sometimes there'll be a snapshot of imaging, again, de-identified. There's no way we can figure out who these are from. And within 48 hours, you'll have a chance for 100 opinions across Canada to weigh in. So there are resources, for obtaining second opinions. Now, you can always ask your doctor, and I think that comes down to the individual doctor-patient relationship. You can say, are these opinion, like, do you need to speak to anyone else about this? Is this is just the only right answer, or are there other potential right answers? And you obviously want to do all these things in a respectful way, but you want to make sure that whatever your shared decision that you've come to is based on an informed decision. And so there's nothing to stop you in Canada from asking for a second opinion. You can engineer that through your family doctor, for example. Your family doctor can refer you to anybody in any province. And there are sometimes logistic challenges of doing that, but there's nothing to stop you in Canada. But you're right, in Canada we tend, for whatever reason, not to use second opinions as often as in the US.
So that kind of curtails us into the next one from Tony is, if a Canadian has found a lump and doesn't live in one of Canada's large cities, i.e. Churchill, Manitoba, where should he and his GP go to find an oncologist who has experience treating TC?
Yeah, it's a great question. And so I would say there's two parts to this answer. The first is that for the upfront sort of diagnosis, and almost always, as I'm sure you've covered on this podcast before, almost always the first move is to have the testicle removed. That's usually the best way forward. Not always, but usually. That can be accomplished by pretty much any urologist who is a board certified urologist. That is what we call a bread and butter surgery. And in fact, we've even published at Princess Margaret on that. We've looked at it, at least for the stage 1 setting. It doesn't matter where you got your orchiectomy. As long as the subsequent decision making is appropriate, then then there's that's much more important than who does the upfront orchiectomy. So I would say I think the step one, it probably doesn't matter where you are in Canada, as long as you're a urologist, as long as you have a urologist who's board certified and can do an orchiectomy, then you're fine. Thereafter, I think we now have resources courtesy of the internet. So Testicular Cancer Canada, for example, and I know TCAF has also, in fact, I think it's called the same thing, like centers of excellence in Canada. They call it excellence centers. But just look through the drop-down menus, and you'll get a view of, in our case, Canada, or in your case, I've looked at it. It's a nice map of the states. You just click on your state, and you can find who in your state is a self-attested expert in testis cancer, and you can ask for a referral to go and see them. And the same thing in Canada. And if that's not geographically feasible or logistically feasible through the healthcare system for whatever reason, then your oncologist can submit the case to the testis cancer Google group, and we can get an answer for what we think is the best, route forward for you.
Gotcha. Speaking of that, we have your province on there. We just need to I need you to fill out the application so we can get all the doctors in there.
Yes.
Tony's next question is, where is the best location in Canada to have an RPL&D, which I guess would be like the caviar of surgeries? Is there a knowledgeable surgeon in every province?
Yeah, I think the quick answer is yes, there is a knowledgeable surgeon in every province. As I know, I'm sure you've covered on this podcast before, I mean, testis cancer is not a common cancer. So it's not like prostate cancer and kidney cancer, bladder cancer. So not everyone will be able to do that surgery at high volume. And the volume of that surgery tracks with the patient population that you serve. So, I live and work in Toronto. And so as Canada's biggest city, I'm 99% sure I do the most RPL&Ds in Canada. But at the other big cities, and each province has a capital city and with high population. And so there is a surgeon in each place, if not more than one in the province, that does, high enough volume of RPL&D. And I think it's okay for patients, at least I guess I have to speak for myself. I'm never offended when a patient says, well, how many of these have you done? Or do you feel comfortable doing this? Or, is this, am I the first case you've seen of this for a while? You can word it a different way, but I think it's okay if you're about to sign up for an 8-hour surgery or however long it's going to be, depending on the stage. But, do you feel comfortable doing this surgery? And it's okay to have that discussion. It's your body and it's your life. And you have to get a sense of their comfort level as a surgeon.
Yeah. What are the out-of-pocket expenses for Canadians needing treatment for testicular cancer? That one might be kind of difficult to answer.
Yeah. So in Canada, as long as you're have citizenship status within Canada and within a specific province, your provincial healthcare system will cover every aspect of your treatment. So if it's chemotherapy, if it's radiation therapy, all the drugs, all the surgeries, the hospital stay, the pathology reports, the CT reports, it's all, you won't even see a bill. It just happens. The only things I can think of that might not be covered, and even in that case, there are some private insurance portfolios that sometimes cover these things. But for example, if you need testosterone replacement, if you've had 1 or 2 orchiectomies, for example, and you're quote hypogonadal and you need testosterone replacement, I think that for those under 65, that is not covered in Canada. The other example is a prosthesis. If you're choosing to have a prosthesis inserted, that is usually not covered by the provincial healthcare reimbursement. And so the hospital may charge you or the surgeon may charge you for that procedure, but that's very individualized.
Unless a Canadian has metastatic testicular cancer and must be treated immediately, what is the average wait time to see an oncologist/urologist?
So I can speak for myself. I guess I can't speak for across Canada, but I would say, so I triage all the referrals that come into me as an individual surgeon. For our cancer center at large, for the testis cancer, all those referrals go to one person, and then we distribute them as we see fit in our group. So if it's more something appropriate for the radiation oncology team, they'll see it. If it's something for the medical oncology team, they'll see it. But I can speak for myself. So the referrals that come to me, I look at every single one of them. And for testis cancer, that goes top of the list because of that urgency to try and get in early as possible for testis cancer so that you minimize the chance that if it hasn't relapsed already, that it's catch it before it relapses so that they never need chemotherapy, and it increases the chance of survival. And so the long-winded answer is I try to see the new testis referrals in, sort of 1 to 2 week. You sort of squeeze them into our already incredibly full clinics, and you just try to squeeze them in and add them on. And it all happens pretty fast in testis cancer, which is a good thing. It's hard on the patients because it's a bit of a whirlwind, but we really try to squeeze them in fast.
Yeah, I think we answered all of Tony's questions in one way or another. I just want to ask the sharing of information. Obviously you're doing this podcast based in the U.S. You did your fellowship at somewhere in the U.S. You're going to talk to IU about the Natera thing. I mean, how does that information? There's no tariffs on the information, right?
Not yet. I guess we'll see what the future holds. But no, there's no tariffs on the information. Certainly the urological community is a relatively small world. The testis cancer community of physicians who really are passionate about this is an even smaller world. We see each other at all the meetings. I have to say TCAF is actually great at sort of bringing us together, and it's a really nice way, and it's great for the patients because the more we talk, the better all of our patients do. So yeah, we talk all the time. We email each other all the time, and we share ideas. We share challenging cases. Like I just got off the phone last night with a colleague in the US, and that's how we get through these things because not everything follows the textbook.
Do you in Canada follow the American Urological Association guidelines, or do you have your own set of Canadian guidelines?
We do. So we have our own Canadian Urological Association guidelines, and there are times when it's different than the American guidelines and the European guidelines and NCCN, which is an American-based another guideline. And some of that we talked about today about surveillance. There's a lot more utilization of surveillance across the journey of testis cancer when it's appropriate. But we have our own guidelines, and they're not radically different, but occasionally they're slightly different.
This last question from Amy is specifically for you, and it might be more than 8 minutes long, but she said she listened to a podcast where she thinks you said you didn't do the EP RPLND. You didn't have the chance to get down to USC and work with Dr. I don't know how to say his name, Danishmand yet, but I believe the episode was several years old. I'm wondering if you offer that technique yet.
Yeah. Great question. I don't remember which podcast that was, but yeah. So the quick answer is no, I have not as yet made it down to see the amazing Dr. Danishmand do his surgeries. I would say that as our robotic surgeries have evolved at Princess Margaret, my guess is that the vast majority that I would have tackled if I did have the skill set to do an EP, so extraperitoneal, EP, RPLND, I tackle it robotically. And I think that the benefits of the EP, RPLND, where you get a shorter length of stay, shorter blood loss, better cosmetic, I think we get with the robot. Like our length of stay is 1 day, our blood loss is very small, and fortunately our complications are quite low. So I think whatever cases I would have done EP in a perfect world, I would travel down and learn how to do that. I think I now do robotically. Now there may be a small proportion, say 20% or so, that Dr. Danishmand would tackle in the EP RPLND that I wouldn't feel comfortable, and I do an open RPLND. And so maybe for that portion, I would benefit. And I'm literally, I just saw him in Madrid 3 weeks ago. I said, I've got to get down there and see you. But these things are hard. You have to put your practice on hold to go down and spend some time. And then we got to line up, some cases with him. And so it's not so easy, but I want to. It's on the list. It's going to happen. But I don't know that it's going to change dramatically what I do up here because of the robot.
Gotcha. Okay. Is there anything else about surveillance that we should talk about that we didn't?
No, I think the main message, because I know it's mostly American based audience. I just the it may be that surveillance as a concept doesn't come up in all of your discussions as patients with your physicians. And so I thought it might be worthwhile just to bring it up here, the basic principles. And so you can ask your physicians when you see them, is surveillance an option for me at whatever stage of disease you might be? And it might be a quick, no, definitely not. You need chemotherapy, and that's it. End of story. But it empowers you at least to have the knowledge that there may be times in your journey that surveillance might be appropriate for you.
Perfect. Hey, that's a perfect answer. Dr. Hamilton, thank you so much for being on It Takes Balls.
My pleasure. Thanks very much for the invitation.
For more information and resources for your testicular cancer journey, visit testicularcancerawarenessfoundation.org.